Good morning. We're very happy to be associated with PCR, and we have a joint learning session. So I have with us Dr. Bernard from UK. So we are extremely fortunate to have him here, and it's a good privilege to work with you. And today the idea is to show everything step by step. It's a learning session, and we have a team. We have my colleague Dr. Muthu, and the anesthetist Dr. Ganapati, and our surgeon Dr. Vijay Shankar is not in the room, and our technician Andrew. So before we begin the case, do you want to have a word with them, and then and they can take it forward, Dr. Thierry?
Absolutely. So it's a great pleasure to be here with you from the cath labs here in Apollo. There's already a feeling of a very confident and established team here. And I think what we would like to do is to allow you to present the case in the arena there, have some discussion regarding the technical aspects of this procedure, and then when you feel you're ready, we can start the case, and we're just going to go very steadily, step by step, through the ABC of a TAVI procedure for the benefits of the main arena audience.
So thank you, Bernard. And thank you very much for joining us for this PCR learning live demonstration. And slides? Yeah, actually we need to present the slides for the case demonstration. So could you please present the case, demonstrate the case?
Okay, so welcome to this session. It's a joint session between EuroPCR and India Valve. I think Kantaro has a long experience with this in Japan, and this is a special session which is a learning live. So you will see a live case, and we'll be able to discuss along the case for each step what is good, what is not good, what should we do in this particular case, and you can discuss, we can ask any question, and we will move in the room to ask you some questions. This kind of session, I think, is very important. It's very helpful, and of course, everybody will be engaged in this kind of session. And we'll have also a smart screen where we can catch some images and discuss on the images and draw something on the images, and you will see on the screen. So Kantaro will present the case. We'll have some discussion, and then we move to the live case.
Sure.
So Sango, I don't know if you are ready to start already? Yeah. Okay. So just.
No, we are ready, but once you are after the presentation, we can start.
Okay, perfect.
We are ready to go anytime.
Okay, so Kantaro will present the case, and we'll have some discussion before you start.
Okay, perfect. So the case is 75 years old female with the asymptomatic severe aortic stenosis, and recently admission for the unstable angina. And coronary angiogram was done in LED mid 70% stenosis and 60% stenosis in PDA. And we also find severe calcified aortic stenosis with the normal LV function, and the STS surgical score is 2.7. This is the ECG. We can see some ST depression in the precaudal leads. And echocardiography demonstrated the severe aortic stenosis with mean pressure gradient of 80 millimeter mercury. The echo also demonstrated the mild AR and the normal LV function, no pulmonary artery hypertension. And this is the CT analysis of this patient. And if we look at the aortic annulus, this is the area. Area is 380, and the longest diameter is 25, and shortest diameter is 19. And if we look at the LVOT, a little bit narrower than the annulus, the area is 345, and this is the ST junction. The size of ST junction is 27 and 28. It should be okay. And if you look at the sinus of Saba, we can see the calcium chunk on the leaflet of the non-coronary cusp. but the size of the sinus of Valsalva is the larger than 30. So this patient have the sufficient size of the sinus of Valsalva. And the team decided to use the MyVol device. I personally don't have any experience, but the aortic annular size is the 406, and the aero-derived diameter is 22.7. That means the oversizing is the 2.3% with 23 millimeter MyVol, and 60% with 24.5 millimeter biprosthesis. And these are the size lineup of the MyVol, and 20, 23, 26, 29, as well as the SFN3. And they also have the intermediate size, 21.5, 4.5, 7.5, and 32 at largest. And the CT also demonstrated the height of the coronary artery. The LCA has the 12, and the right coronary height is the 16. The height of the ST junction is the 20 millimeter. As you can see, there is the severe calcification on non-coronary cusp, and the CT clearly demonstrated the fusion of the left and the right coronary cusp. That means the type 1 LR of the bicuspid valve. And this is the angulation of the ascending aorta, not that much horizontal. And this slide shows the iliofemoral axis. The both sides of the iliofemoral axis are good size. And the height of the bifurcation of the femoral artery is low enough. This is the coronary angiogram. So we don't see the severe coronary stenosis. So what is the plan? This is demonstration.
Okay, thank you very much, Kentaro. I think we have intermediate risk patients who had relatively simple aortic stenosis, except the fact that there is a bicuspid valve with a lot of calcification, and the fact that the left main is relatively low, 9 millimeter from the annulus. So maybe we can start by asking to the room, who will go to surgery in this kind of case? Nobody?
Please raise your hand if you would like to send the patient to surgery.
TEVAR? And medical treatment? Okay, so TEVAR in the majority, the vast majority. So maybe we can move to the room now. They are ready since 15 minutes. So maybe we can ask you what will be your plan for this case? Sengo?
Yeah. Theory, so we have seen the CT, so this patient has severe aortic calcified aortic stenosis, the bicuspid valve. So we plan to do this by transfemoral approach and use conscious sedation. And our anesthetic team, we plan for conscious sedation. Maybe we'll give a mild sedation as a patient is a bit restless and anxious. And so we want to use the right groin. I think you would have seen the CT. Both the right and the left looks good. So we want to use the right as a principal groin for the main sheath. And then the left side, we've already placed a temporary pacemaker, a balloon tube pacemaker, and we have a line for the pigtail. We have arterial line for the pigtail. And we are just going to start. Do you want to add? Yeah.
I think there's clear support for a TAVI approach here. It's a nice case on CT for the 23 millimeter MyValve device. We've got nice clean iliofemoral vessels. I think the only challenge will be crossing the valve. It's a very tight valve with a very high gradient. But let's see how that goes when we get there.
So we are using, our plan is to use ultrasound guided puncture, and we want to use 2 proglides, and then go with the confida wire across the aortic valve, use a balloon, 18 millimeter balloon to predilate, and then use a 23 millimeter MyValve. So that is the plan. So let's start with the ultrasound guided puncture. So we were used to using a fluoroscopy, but now we moved to ultrasound. So we can see the bifurcation down, and then we move more above, and you can see the femoral head very clearly there. So So this is where we want to puncture. So we can puncture with this, or we can go more to short axis. So we prefer to go to short axis, and you can see the artery. So just have to puncture. You need to give, okay.
So can you show your hands
So
also?
Yeah.
Can the camera show your hands?
Can you show the camera down?
We're only seeing the flora in that image, so we don't need to see the flora. We just need to see your
No,
hands.
So can you focus the camera on the hand? Can you see it now?
Yes, we can. We can.
So can you see the ultrasound also?
Yes, we can see the ultrasound, and we can see you
So
putting
I am just going to keep the center of the probe.
here.
Yeah, it's coming there. Yeah, so I'm going.
So it's a nice single operator technique. The left hand is holding the ultrasound probe,
Right?
and the right hand is obviously using the needle. And you'll just see the track of the needle coming now. You can see a little bit of disrupted movement in the subcutaneous tissues there. Just approaching the vascular lumen now.
Maybe. No. So we
So
can
you can see that this is one of the ways to puncture the femoral artery, but certainly there are so many other ways, and typically in my lab we don't do any micropuncture. We do it from the other side, inject and do the middle injection.
The other option is
through
to use a long axis. We are not clear with the short
retrograde
axis.
injection from the other side. Dr. Said, what do? You do this ultrasound thing, or you do micropuncture?
So maybe we can ask
So,
to
I
Bernard.
think theory will come to the puncture. You have certain slides related to the puncture at this time. They've now got the needle into it, and Thierry will be discussing that.
Yeah, so maybe we can move to the next slides. On the left, you see the micropuncture technique. Of course, you have many ways to do the puncture, which can be angio-guided, like here. You can use a pigtail as a marker for a specific puncture, so you don't need to have your hand on the screen, and you can do the puncture directly in the pigtail. I think it can be very useful, especially when you are in the learning phase. Of course, with experience, and for people who are doing a lot of femoral cases, in the majority of cases, you will not need this kind of approach, but it's very important to be sure that you are doing the puncture above the bifurcation and below the epigastric artery, because the risk is very high if you go too high or too low. And sometimes the safe zone can be very short. So that's why in this kind of situation, the pigtail approach can be very useful. But of course, echo-guided puncture is also very useful. And many people in the UK and in other countries, I don't know, Kantaro, if you move to echo-guided puncture too?
Yeah, we're doing the echo-guided.
Echo-guided, okay. So I think it's a very, very good approach and very safe.
So this is the so Thierry. Yes, Praveen just mentioned about. So we'll just dwell on the punches. Praveen just mentioned the bullseye. This is what we use in our lab as well. Should everybody be getting on to an ultrasound guided puncture, or are you quite okay with the bullseye type technique where you get the catheter from the contralateral side, put the pigtail at the spot where you want, and then just hit it?
Yeah, I think it's a very good point. I'm not doing echo-guided puncture, except in very few
Shall we
cases.
wait there so we can show it?
Because I'm old and I've learned a lot of transfemoral approach when I was young. So I don't use it, but I really recommend to use it when you are in the learning phase, or if you are young doing a majority of cases through the transcranial approach. And this is the case in the majority of centers. Yeah, you can see on this screen that you can, in the long axis, see clearly the bifurcation, and then you just have to turn the capture 90 degrees in order to do the puncture in the center, because this is the two rules. One is to be above the bifurcation, but the puncture in the center is a guarantee of a good result when you do the closing. If you do a lateral puncture, it will not be good. So this is very important, and this is exactly what they have done during our discussion. So maybe, Kantaro, you have some recommendation about that, you have experience.
Actually, it is really important to puncture the middle of the vessel. That is why the echo-guided puncture is so important. But in case of the patient with severely obese patient, sometimes echo doesn't work. So in this kind of case, I use picture catheter, and puncture the middle of the picture catheter is very important to make sure that you're in the middle of the vessel. Okay.
So Thierry, Kentaro, if I can just add there, we're ready to move forward with the procedure.
Yes, please.
We hear the points that you're hearing the points that you're making about making sure that you hit the front wall of the artery with a central puncture. That's very, very important. And as Kentaro says, it's important also that you have some flexibility with your approach. So ultrasound is very good, but it's not possible in every patient. So to have the contralateral access with fluoroscopic approach is also very helpful, particularly for obese patients. We've also noted in the UK that there is a generational divide. So as Thierry was saying, those of us who are very experienced with femoral access for PCI procedures are far more comfortable with fluoroscopic approaches than our younger colleagues who are now very ultrasound based. And as we move forward through the generations and TAVI becomes in the hands of the current younger generation, I'm sure we'll see that ultrasound access is very much the 100% preferred technique of choice. So we're now ready for the ProGlide sutures, and we want to move forward because we're just achieving hemostasis with pressure at the moment. So Sengo, if you could talk us through the steps of the ProGlide deployment, please.
Yeah, so we plan to have 2 ProGlides in place. So we have this ProGlides flushed already the wire. So we want to place at 10 o'clock and maybe at 11 o'clock and 1 o'clock. So we would maybe they can explain on what we mean by 10 and 11 o'clock. So the wire out. So I'm just going to introduce the ProGlide, just making sure there is a good flow. You can show the camera here. I can see the flow. So I'm going to go a little at 11 o'clock.
Do you have the wire?
As you can see here, the ProGlide is being inserted, and usually we use 2 ProGlides. Dr. Kentaro?
Yes.
Yeah,
Yep.
2 ProGlides, and the only discussion over here is that what should be the location of putting these ProGlides, because earlier when the angle we were using initially more than maybe 90-degree angle or up to 90 degree, the chance of cinching the vessel is higher. But the problem is if the angle is too less, then the chance of putting a third device also comes in. So how do you manage that? And Sengottuvelu, can you discuss this point as to what is the location of 2 ProGlides you are going to use?
So we are now planning to do 11 and 1 o'clock. So what we have seen is, I think Kentaro will agree with me. Sometimes we put 2 ProGlides, but very often we get a good hemostasis after deploying the first 1 ProGlide, and we particularly in our patients when we have, and I think Kentaro also has the same thing, using 1 ProGlide in Japanese patients.
Yep, exactly. So actually, we started our experience with 2 ProGlides, but we only tighten 1 ProGlide because we Japanese has very small uniform access. But nowadays, we only deploy 1 ProGlide.
Why?
For the sake of the financial issue. And usually 1 ProGlide is sufficient for the hemostasis for 14 French sheaths. And in case that doesn't work, so we may add 1 angioseal 8 French. That is our current practice.
Yeah, I think it's particularly true when you have small vessels, less than 5.5 or 5.8. So this is what we are doing systematically in our center. So provisional 2 proglides when the femoral is small. So we close the first one. If we have good results, we remove the other one. If not good result, we continue to work and we check before closing the second one. We check that we have no tight stenosis, because if you have already a tight stenosis with one proglide, with the second one, the risk of occlusion is very high.
Yep.
So I think this strategy is very useful and decrease the risk of complication in patients with small vessel. On the opposite, when you have a very large vessel, 8 or 9 millimeter, usually 2 proglides are good, but sometimes you need a third one, or you need to complete with non-juicy. So I don't know if you have the same experience.
Actually,
Maybe you have not patient with 9 millimeter.
yeah, it's really rare to have the patient with 9 millimeter vessel, but actually the one proglide is usually sufficient, and sometimes we may need the second one, and the provisional additional angiocyte works also very well. And I prefer using 2 mechanisms, the suture mediated and plug for the better hemostasis. And we don't hesitate the contralateral ballooning in case of the poor control of the hemostasis.
So Sengo, can you...
So Sengottuvelu, okay, what have you done till now? We saw you put the proglides. We discussed the 9. We discussed the 11 and 1 position. 2 parallel proglides also can work equally well, rather than angulating them.
Yeah.
You just move them on one side and the other, and that works well. But what have you done now? So you did that. Initially you put a 7 French sheath
So we
in.
just put the proglides, and now we put an 8 French sheath after the proglide.
Yeah.
And the heparin is given now, and we are just going to do a iotogram with the pigtail and then take the big sheath and the python sheath.
Okay. So
Sengo,
you have
Sengo,
the right side. What about the left side?
We already have an arterial and a venous line. The venous line has a pacemaker, a balloon tip pacemaker, which we already have done, and we're just going to take the pigtail through the left side.
So Sengo, can you tell us when you start heparin and what is your objective in terms of ACT?
So it's important to give heparin after the proglides, because in case you have an issue with the proglide and bleeding. So that's the reason we want to give, and we need to make sure we give the heparin before we introduce the big sheath. So once the proglides are securely placed, and then we before the big sheath, the heparin is given.
And what's the target ACT in your lab, Sengo? 250, 300?
Yeah, we keep it around 250.
So we've already got some information from an earlier aortogram and perhaps from the CT about the optimal projection angle.
Yes, so the CT, we have an angulation from the CT, but often we see that there is some minor modifications required when we use the fluoroscopy. So the CT angulation was a bit different now. When we do in the fluoroscopy, we have got a AP with 4 caudal. So that's what we want to do now. Plain AP with 5 caudal. Yeah, 5 caudal. Just.
So in this case, we have already discussed
So
the axis.
maybe we can discuss the importance of coplanar view, and
there will be some patients where we cannot do a percutaneous access, and we have to identify those cases, and those will be the patients where the calcification is anterior in the femoral arteries, or there is a more than 180-degree calcification. In these patients, typically we start thinking of open surgical approach, which is still used in about 15-20%.
yeah, that's fine. So just play that, please.
There's also the situation of anterior. I think that should be discussed. I don't practice it, but some people leave an overnight wire crossover for bailout. Now, when you close per close, there's an advantage of stopping blood flow, which is a dry perc close, which means that if you actually stop blood flow, your perc closes work more rapidly. And if you don't, and that's understandable because you just decrease the pressure on that side completely. And that's helped by the fact that emergent access can be had if you lead an overneat wire. Crossover, you've already done the crossover earlier, and therefore you can always leave a wire soon after the perc closes have been placed.
Yeah, that is a very important point. Sometimes the crossing over technique is very important to secure that to avoid complications. So that is important. And now the team has proceed to the perpendicular view. So the team has make very nice angiogram to demonstrate all the cusps are in line.
Yep.
And
Go back one
could you
to
please
show the aortogram.
see this slide to identify the
aortogram.
coplanar view? In TAVI, we need to make sure that we can see the very good coplanar view.
Can you play it
That
first
means
and
that
then we
all
can
the
freeze
three
it later?
cusps are in line,
Maybe
at the same line. So,
maybe
Dr.
more-
Sengo,
little more
could you
contrast.
please explain the direction of this patient? Are you happy with this projection?
Yeah, we have just done an iotogram, and this is what we have. Probably there isn't enough contrast, maybe. We're not able to see the cusp clearly, so we'll do one more, and then
Okay.
inject. Yeah, this looks good.
Okay.
Yeah.
As you
I
can
think
see,
that's a
all
nice angle. The pigtail perhaps could be in the non-coronary cusp
Yeah.
when we come to valve deployment, but we can consider that later.
Fill it up. Play. No, we're not
Thierry
showing the entire-
Cantara, we're going to move on because there's a little bit of oozing around the 8 French sheath, so we'd like to move on to put the python sheath in place, if that's
Yes,
okay with
please.
you.
Of course.
So Sengo, do you want to explain the python sheath and
Yeah,
demonstrate it on the
sure,
table?
Sure.
So the pigtail is right now
Can you get the
not
sheet?
in the
Get the
non-coronary
sheet,
cusp,
please.
which we would like to have. Yeah. We would like to have it in the
In each
non-coronary,
step.
at least at the time of deployment.
Can you
In
focus
case
on
of
this,
the,
please?
the bad coplanar view, we usually use the rule of the follow the right cusp rule. So do you have the slide for the follow the right cusp rule? And that means if the cusp is a little bit higher, we go to the cranial to fix the angle. Now the Sengo is demonstrating the python sheath. This is the expandable
Okay.
sheath, right?
So as you can see, this is the python sheath from Merrill. So this is you can see the green color sheath. Over that there's a dilator, and you have the Merrill logo. Normally we make sure the Merrill logo is faced up. So the advantage of the sheath is this is only 14 French sheath. It's an expandable sheath. So the valve can be, when we insert the valve, the sheath expands transiently to allow the valve to move. And when we start putting the valve inside, there may be some initial resistance. And once the valve crosses, then it becomes more smoother. So basically, this sheath allows to, expands and allows the valve to go inside. So the tip of the sheath has got barium and can be seen radiographically. And the valve systems are nicely done so that there is no leak.
Okay, Sengo, if the patient has the oozing,
Okay.
please put your sheath.
One of the most important aspects is after the 8 French or 7 French, whatever you use initially for the pro glide deployment, always next steps of going up with dilator and getting to the sheath are always on a stiff wire, an amplex wire, which therefore allows you to put these things in safely.
Change the stiff wire.
So you also pointed at a very important point that the sheath
Show
should
down.
be advanced over
Show
stiff
down, show
wire,
down. Show
not
down.
normal wire.
Show down, please, nicely. Show down.
So did you use
So the python is
dilators
going inside
prior
now.
to this
Go
sheath?
down.
What was your sequence of?
No, we didn't. We can use a dilator if there is. We can show. We will use a dilator. Come, can you show down?
Yeah, we see
So we
that.
will give me the dilator alone, so it makes it much more better. Yeah, give the dilator.
Okay.
And what is
Dilator.
also very important when you push this kind of sheaths which are activated by water is to have really something which is very slippery. So did you add some water on the sheath, Sango? I think it's very important. to be sure that you have something very
Yes.
slippery.
Yeah.
Because I was surprised that you had some resistance when you pushed the sheath.
Yeah.
So I was just going to comment on the fact that
Sometimes we use propofol also. Sometimes if you
yeah,
use a propofol,
on
sometimes
this sheet
helps
you
to
won't need it, but I
Yes,
always say certain things. Once
Yeah,
you create
exactly.
a protocol, don't deviate
Yeah,
away
the
from
dilator
it.
is good.
So if you decide that you created a
Yeah.
protocol of going from an 8 French sheet to a 14 French dilator, and then the sheath itself, and that's
Yeah,
more than enough, that's all you need to do. Stick to it. There are advantages of it. The advantages are that firstly, you're able to feel the vessel. Secondly, if there were any areas of narrowing, you're automatically stretching them. It allows you to get the feel of how your sheath will track up, and therefore it gives you a good idea about straightening of the bends of the and calcifications of the femoral artery to allow your valve to go up. So there are inherent advantages of going up, and follow that protocol. Don't think that on
Can you show
one
down
patient
and
you won't do
put
that, on another patient
that's better.
perhaps you'd use 2 dilators. I think it's a system, everybody follows it.
In fact, either one has these, serial dilatation, these dilators, or now we have a universal dilator, where you can use one dilator to do the entire dilatation and then put the sheath inside.
So, Sengo, do you feel any resistance?
So I think now it's okay.
It's okay.
Yeah, there was a small resistance when I had to
Okay.
insert the sheath,
Perfect.
but once that passed, it's fine.
Yeah, I think there is two
There was some
important
resistance
points.
initially.
One is to put water in it, so I systematically use water at just before penetrating. And the second one is to check that the skin is sufficiently open, because if it's less than 6 millimeter, you will have a lot of resistance when you enter the femur. So these are the 2 points which are very important, because in this case, I do not anticipate any problem with the sheath.
Yeah, just flushed.
In fact, that is a very
Have a
important
suture,
point,
please.
that at any point in this whole trajectory, if the vessel size is less than 6, because this sheath is although it is 16 French sheath, but it will expand inside once we do the valve, put the valve inside. So it has to have the vessel size to accommodate the valve inside, because it goes up to 24 once it splits inside.
And
So-
skin preparation is
So
also
Thierry
very important.
Cantaro,
Yes,
Yeah.
please go ahead.
so we're just putting a suture in. We interrupted you when you were talking about the 3-cusp anatomy.
Yep.
And how to follow the right coronary cusp. So do you want to go back to that slide and just explain that to the audience while we just secure our sheath in position?
Yes,
Okay.
sure.
Thank you.
So please show follow the right cut.
Yeah, this
One.
one.
You have one more
Previous
sheet
one.
right there.
There's a slide of the right coronary cusp rule,
Just
Good, we
before.
change it.
which shows,
Yes.
this is the one. Go ahead. Thierry, you want to explain that? Or
Cantaro.
Contero?
Cantaro will do it. Yeah.
Talk
Okay.
about the,
So actually, as you can see, there is
We'll
the
change the
follow
sheet
the
rule.
right
It's
route.
kind of split here.
As the picture
Maybe
shown the left lower panel, if the right coronary cusp is a little bit higher than the coplanar line, that means you can move your
See this here.
image
change
intensifier
it or
to
leave
the
it like
cranial, just following the right cusp,
Yeah,
and
change
then it will be
Change it.
corrected like the inline. And
Change it. Then
usually we
first time we will
we
change
move the
this.
10 degrees each, and if there is a huge difference, we use 15 degrees. In case of the very fine tuning, you can just move the 5 degrees.
Just play that, no? Play the diagram.
This rule is extremely important to get the coplanar view with the minimal
Can
amount
get the
of the
dilator back.
contrast.
Dilator back.
Okay, so now you can. The next step is to cross the lesion, I think, the articulation. But while you are doing that, I will ask to the room if they have any question or comments. Please feel free to ask. There is no bad questions. All questions are very important.
this is an interactive session. So this needs participation from your side. The reason this is being done step by step is to give you more experience and give you tips and tricks on every aspect of what a case needs. So please go ahead, interact.
Okay, so maybe you have a question. Okay, go ahead.
So your timing is perfect.
We still have 30
So we
minutes.
managed to cross the valve. The gradient, the peak gradient, as you know, on echo was 140. Sengo, with considerable skill, managed to cross the valve twice because initially the wire positioning was not quite optimal. So we took the wire out, we recrossed to get a better position. We've put a pigtail into the LV cavity. We then used an exchange wire, and we've now exchanged in a confeeder wire. And on the way, we also confirmed that the peak-to-peak hemodynamic gradient at catheter was 110 millimeters of
Can you show
mercury.
that, please? Can you show that on the screen?
I'm not sure if we're able to project that, but this is very, very severe aortic stenosis. We've just rechecked the threshold of our pacemaker. I'm getting a thumbs up that that's in very good shape. So I think we're now ready to move towards the balloon valvuloplasty.
Absolutely, yes.
Excellent.
Good.
Okay, so,
So, in view of this calcium and a bicuspid valve, we generally have a policy of pre-dilating, particularly in a bicuspid valve. And we were using an 18 millimeter balloon. It's a ZMed 2 balloon.
So, Sengo, how did you decide the size of the pre-dilatation balloon? Why do you use 18 millimeter balloon?
Okay. So we looked at the annulus diameter. The minimum diameter of the annulus was 19, and the minimum diameter, the LVOT, was a little smaller than the annulus. The LVOT diameter, minimum diameter, was 18.6. So we wanted to be less than the minimum diameter. So we decided to use an 18 millimeter.
I think that is a very important point. Please do not exceed the minimal diameter of the annulus to avoid acute AR.
But for bicuspid, I think
Sure.
doing a pre-dilatation is almost 100%.
So Contero, can you actually, therefore, this is the time to go over the CT.
Yep.
And what do we actually, what are the important numbers that we note on a CT?
Okay, for the
There are
measurement-
numerous numbers out there
Yeah.
which can make everybody confused. So I think it's a good thing to discuss what are the important numbers that we look at which change our strategy
Yes.
and a selection of hardware.
That's a really important point. And for me, it's really important to find the smallest part of the aortic
Pacing
valve complex.
Yeah, pacing
And
on.
for this case, if we look at the annulus, the number was 380.
Okay.
And if we go up to the level of sinus of Saba, could you please show the CT image? And we can see
Facing
the very large sinus of Saba. I personally measure the intercommissural length. That means the, in this case, L on R is fused. We can measure the distance between theory. Could you please, yep, the intercommissural length. Could you please indicate the, that means this one and this one. In this case, this is 25 or 6. That means it's smaller than 23. And we also need to take into account the amount of the calcification. And I think in this case, the annulus is still smallest part of aortic valve complex. That means that I would choose 23 millimeter
Can we
balloon
replay the
expandable
balloon?
valve. And some people measure the supraannular measurement, but I don't really understand how to measure the supraannular measurement. Terry, do you have any
No,
thoughts?
I fully agree. So for bicuspid valves, I think it's very important to measure the annulus and also the intercommissural distance,
Okay, well, let me do
because
that. It's okay.
it could be like that, it could be like that, or it could be like that. So according to this, you will do you will select a different valve size. In this case, you have the annulus size is
We'll demonstrate this on the
22.7.
table.
Intercommissural distance is higher. I think it's around 27, 26. And so in this case, the shape is just like that. Excuse me. So from you measure the intercommissural distance from here to here. Yeah, yeah. You make a straight line.
Straight line.
Straight line. Yeah, this is what they are doing. Yeah.
So,
Yeah, of course.
you
but,
want to answer that? Yeah. You could answer that.
Yeah, so I think you should do something. So with a 14 millimeter balloon, you will not do a lot on the valve. So I think the best selection, the best compromise between the risk of perforation or the risk of acute aortic regurgitation is to use a diameter just lower than the smallest one. So the smallest one
So-
was 18.6 in the LVOT. So 18 is a good choice.
So we must remember that these are eccentric orifices in bicuspid aortic valve. They're large chunks of calcification, and inability to cross a valve is a bad thing. And bad thing especially because if you're using a balloon expandable valve, not in this case, luckily my valve can be brought back into the sheath. But sapien, you just have to start the whole procedure all over again. So you don't want to be in a situation where you will not be able to cross the valve. So that's important. The second aspect is, so therefore you have to get this right balance between adequate orifice and having moved the calcification away and not creating a paravalvular leak. Oh, sorry, not creating an aortic regurgitation. That's not a paravalvular, creating an aortic regurgitation. The best balances lie between 18 and 20 millimeter.
Okay, so
Yeah,
the
let me
team is
clarify
waiting.
because
So Thierry, Ashok,
Yeah.
Kentaro, can we come back to the lab?
Of course.
Yeah,
Go ahead.
Please.
go ahead.
Go ahead.
Andrew, show the steps. Show what we've
So
done.
we've done a balloon valvuloplasty with an 18 millimeter balloon. We're just going to show that to you now.
Balloon.
Yeah, we have seen it.
Next one. Next one. Here. So you see nice balloon expansion. You've already seen that. So now we're in a position to move forward with the MyVal device.
Good.
And Sengo, if you could explain the device. Firstly, the nose cone and the valve, and then the back-end delivery system. Sengo.
So this is a 23 millimeter MyVal. So you can see this nose cone and the valve which is loaded, and we also check the position of the valve. We can see the skirt down. You can see the skirt should go into the LV. So proper orientation of the valve, and the handle. You can focus on the handle. So the handle has a, you can see the wheel there, which can be rotated to flex the tip of the catheter. So this delivery system, we can flex it. You can see the arrow marks, and this is we don't have to. It's already crimped on the balloon, so we don't have to put a position inside. So we could go directly inside, just like a stent, and go and deploy. Okay. So it's
that's
already
the
been
loader.
loaded to the
That's
wire.
the loader.
Yeah,
First you push the loader
wire's
inside,
coming
then the
out.
valve.
Just give forward traction. Yeah, it's fine.
Okay, Sengo, please.
So
go
we're
ahead.
going to push the loader. Yeah, can you show it now? So you're going to put the loader and the valve. Yeah.
And you have also a two-stopper, proximal and distal to the stent, which
Can
makes
you
the
show
stent
down?
not moving when
But
you are
sometimes
pushing it.
with this Python sheet, there can be a little problem because earlier we were using the 26 French sheet. Now this is the Python because it is expandable sheet. Once you're pulling back, it can be a problem.
Show the wire.
See the heart?
Yeah, wire.
Once, if in case we have
Yeah. There is some amount of resistance.
So the resistance is at 2 points. Remember, it has to expand.
Yeah.
It's only a 14 French sheath, but the vessel is not that size. Correct? So this is what you said earlier, and we said that's correct. Because in that way, you must stretch both the sheath as well as the vessel. And what he's feeling is not the resistance of the sheath alone. He's actually feeling the resistance both at the entry point, which at the moment is there, and then there is a narrow segment of that vessel. This side was 6 millimeters at the lowest point, and while we may say 6 is okay,
Why the show?
you need to stretch that area. So resistance relates not to the sheath alone, it relates to the vessel.
What is very important is to push not abruptly, but just make
Slowly,
a big
constant
pressure.
pressure.
like pushing somebody. So if
So
you
now we
push
start
like that,
using
it will not work. But if you push like that, okay, it will work. Thank you for your help.
So do you want to see the valve coming back into the sheath?
No, no, no. I think you can go ahead. Don't.
I think you should go ahead now. Though the valve will come back.
Okay. Okay, so we are going to just move the, come lay over please, slowly. So as we go, we also give a slight flexion and go forward. You can,
Okay, so now Kantaro is doing what we call the no-touch technique. So you avoid the external part of the aorta or the internal part by adjusting the flex to the direction.
so we are ready to cross the valve, come to the same
Bring
view.
the pigtail down.
And it's important to make the pigtail in the non-coronary cusp. Can you put a wire? I think, give me a small test in the pigtail, please.
Maybe blood pressure is slightly low.
Yeah, so can you give me a wire? Couldn't go without a wire. Okay. It's
okay.
gone left.
So this is a very important
Yeah,
step
it's fine.
because
Okay.
you will be sure that the
Test.
pigtail is really at the level
Test.
of the annulus. So you don't need to. So
You
you
just
see
go a
the,
little bit
the
more.
pigtail is too much
If it's
proximal. There
possible.
is about 4 millimeter or 5 millimeter which
No,
are
it wouldn't go.
below the level of the pigtail.
Yeah, it's okay. What do you think?
So
It should be
it's okay to deploy.
Yeah.
Okay, so if we cross the valve now,
So we'll cross
when you're
the
ready.
valve. Yeah. Give me a test again, the pigtail. Is it okay? Test.
Do you feel resistance?
No, we're just getting our pigtail aligned, Kentaro.
Ah,
Just one moment.
Yeah, sure. Please take your time.
Pigtail has gone a little bit up.
So this is very classical.
I
when you
think,
push the
gi-
valve, the
give me a-
pigtail can move.
Give me a
Like
test,
that.
please.
So you can readjust the position of the pigtail
Just
just with
repriming the
wire.
pump, sorry.
Yeah.
We could maybe ask Ashok, has there been any experience with direct deployment of the MyValve device, or is balloon
Test.
valvuloplasty essential, do you
Yeah,
think?
that's good.
Yeah, it's
We can keep it.
in the study,
See the mark.
nearly all cases were pre-dilated. It was in the protocol itself. In the subsequent clinical use of the valve, I think it's practically 95% have been pre-dilated.
But now,
Yeah,
so
take a
those
picture.
patients who do not have heavy
Come to the same
calcification,
view.
those who do
Gordon.
not have very severe
Same view.
stenosis, you can go without.
That's right. So
pre-dilatation.
that's why the 95% has been pre-dilatation. That's been as a
Take a picture
caution
and then put it
rather than the necessity.
Okay.
And as the experience
That's
with the
okay, so
valve
go
has
to
grown,
pacemaker.
remember this is the first use of a direct balloon-mounted valve without any sheath.
Maybe a little bit lower.
Slightly lower.
So what do you think of position, Sengo?
A little bit too high.
Yeah, I am happy with this position. We take another
Looks good.
picture.
Yeah.
Okay.
Take one more. Just see what you feel.
Looks good, huh?
So we can see the dark
So-
zone. We can actually see that your cusp is at the second dark zone, and I would accept this as a good position.
Yeah.
Okay.
And also because
So
the pigtail is not
we go
really at the
pacing,
bottom
yeah.
As
of
a starting point, it is a good
the
position,
sinus.
and we can take a shoot once the pacing is on.
Yeah, we can do a shoot and then decide.
So would
Okay,
you
pacing
remove
on.
the pigtail before deployment or not?
Yeah, before the deployment, we'll remove the pigtail.
Okay.
Pacing on.
Pacing is on.
Okay, pacing on. No, I don't have the pressures down yet. So we need a better down of the pressure. Yeah, it's better now. Yeah, yeah. Yeah, inject. What do you feel?
That's good enough.
Okay,
good.
it's okay.
Okay, go
Good,
up.
Go.
Go up.
Yeah.
Perfect.
Okay.
So this is what we call a slow inflation, and this is very important because you can adjust the position
Pacing
of
off.
the valve
Facing off.
during deployment. And then when it's fully deployed, you take time.
I have it.
You see there took time. I think it's very important. Pressure will go back. It's very important to take time to have a full deployment of the stent, like for coronary arteries.
Now the blood pressure is recovering.
So we have some QRS widening, as you see, but the blood pressure is coming up very nicely.
Yeah, you had a very long high rate stimulation, so I think it's.
So it is not necessary to pull out the pigtail unless until, in this case, it was not very good position. But if it is in the direct non-coronary cusp, you can leave it also. I think Ravinder,
Yeah.
you agree with this?
I leave it.
Take the valve back.
Also
I also leave it. I don't think I
Yeah.
need to add another step.
I fully agree with you, but
Never.
the pigtail
So
was
we generally don't
Like that.
to do it, and sometimes we
Never,
switch
never
on
ever had a
our
problem
comfort
with
level, we
leaving
can-
the
no.
pigtail.
If the pigtail is
Yeah.
straightly direct in the non-coronary sinus, it's okay.
Yeah.
But here
Coming
it was
out.
in
Yeah.
the
This
non-coronary
is
sinus,
to be removed.
and then in the aorta. So the risk is not low. But in other situations, it's okay. You can leave it like that, and it's a good marker for the position. Okay, so now you have the patient that some spontaneous adrenaline injection. So that's why the pressure now is very high. So it's auto injection.
Now the team is checking echo.
So we're going to give you an aortogram, and then we've got some echocardiogram images appearing at the same time. So let's do an aortogram when you're ready, Sengo.
Yeah.
The other
Can you
aspect is
do
that
a-
you don't
make
need
it,
to keep injecting contrast itself. The first time if you've injected and you
just a second.
found
You can
yourself
come more caudal, little more
and
caudal.
your pigtail
Just
is
to
in the
flow
right
the
position, then I don't even inject contrast at the time of dilatation
Yeah,
because
more,
it's so
some more.
predictable when it expands.
That's okay.
Yeah. I
And
fully agree.
injection's not going to
Ready?
help you.
For an itogram.
So it's very important to remember that these patients have poor
Ready?
renal function in the majority of cases. Creatinine clearance, the mean is about 50, 55.
It's because of
So
the
very
voice.
nice.
So when you actually
So
look
we-
at this,
So we have an.
it's important to remove the parallax and
I'll
see the
talk,
valve.
Thierry.
Yeah.
So we have an echocardiogram. We're not showing that live now, but there is very mild valvular aortic
I
regurgitation.
think wire is there still.
So we're
there.
going to take the stiff wire back, and then we'll reassess with echo with the wire back in the aorta.
Okay.
Yes, please.
The diastolic
Do
pressures look
you
very
want to check
good,
the gradient? Or?
70.
Do you want to show gradient?
Yeah, we can. Just
Okay,
show the pigtail
so
back.
we're going to quickly do a gradient for you. So we'll do that as an interim step.
Actually, you
Okay.
still have the wire in the left ventricle. The angiogram shows very mild AR, so it should be okay.
Just here, the rooming gradient, just look at the valve long axis.
Yes, for them to see.
So do you have any question in
Okay.
the room? Yes.
Yep.
Yeah, reduce the gain, color. Yeah.
Shit, it's bleeding too much, huh? It's bleeding. I think we
That's
can't-
why I think echo is the
This-
best.
okay, valve is bleeding, so we cannot. Can you check? Okay, I think we are fine. Okay.
No, this
Let us
at the
get this out. Get the wire.
it's at the moment there's wire. So echo can tell you whether it's central, whether it's paravalvular.
Come.
Uh, But again, the best idea is, of course, the stiff wire will always splint it.
This.
And that's very important. I think you need to look at the hemodynamics at the same time.
Now check now.
See the
check now.
diastolic pressures.
Dynamics look very good. There's nothing on the echo. Echo looks clean.
Okay.
So, Sengo, could you please explain?
Can you show the echo on the big
finding
screen
by
for them, please?
echo?
Show the
we are
echo
seeing
on
the
the big
echo.
screen.
And remember
Yeah.
that the pigtail is not going to splint
Show the color.
the valves. The stiff wire is what splints the valve.
Could you
It's perfect.
comment on the echo finding?
You put the stiff wire back.
And
Stiff wire.
another view, a short
Yeah,
axis,
stiff wire.
and also 3 cavity view.
So can you hear us in the lab? We've got color, and then can we go to short axis? So Thierry, there's no aortic regurgitation now on color Doppler.
Yeah.
We did a quick hemodynamic study. We're quite keen to take the sheath out now, but there is no peak-to-peak gradient across the aortic valve at all.
Right, can we,
And the diastolic pressure was low,
Stiff wire.
and with no hemodynamic indicators of significant AR.
great.
We're now showing it in short axis here. Can we put some color on the short axis, please? And you can see here again, there is no significant aortic regurgitation.
Better.
No AR.
So we're now going to move on to sheath withdrawal.
Okay.
So would you
Okay,
make
the mean
final
gradient by echo is 4.
angiogram?
Yes, we will do an
Okay.
iodogram.
And the mean pressure gradient is only 4.
Okay.
It's,
Okay.
it's 4.
Correct.
Could you switch to the
So if we could
angiogram?
bring the camera in on the groin now, please, for the closure.
Okay.
So, Sengo, can you explain your
Can you show the camera here?
your strategy when you close the vessel? Do you give some protamine to the patient or not? What is your strategy?
What we generally do is make sure we have a good monitoring when we remove the sheath. We put the dilator in, have the stiff wire, and when we remove the sheath, we have the practice of taking a wire crossover from the other side as we remove the sheath out. That's how we do, and we deploy the ProGlide, and we still have bleeding. We reverse generally 50% of protamine. That's what we do. And what is your general policy of doing
We
that?
don't reverse the heparin until we're happy with the closure.
Yeah,
So we
yeah.
leave full heparinization and give
Yeah.
protamine after the final angiogram.
Yeah, exactly. That's what we do. But 50%, depending on the bleeding, we decide that actually. Okay.
So the best strategy I think about heparin is never reverse it completely. Agree with the fact that after you close, you reverse it partially. Because after all, you've sutured the artery, you actually had devices in, and you don't want thrombus formation of any sort even post.
Dilator.
And getting half the heparin down is good enough, and let the rest of the heparin wear off, and that avoids thrombotic complications in a big way.
Absolutely, yeah. It is not, in fact, necessary to give protamine also if you get good complete closure. There
Yeah,
is no ooze,
yeah,
it's okay.
exactly.
It varies.
Yeah,
from
many of the
center to
times we
center.
don't need to give protamine at all.
In my center, we after deployment of the valve, if we are happy with the result, we decrease. We inject protamine as 50% of what we have injected of heparin, and it works very nicely.
That's
But of
right, that's
course,
what we said,
You can
partial
do it
reversal.
without any protamine.
And what is your practice of your safety wire? Do you keep one wire when you remove the sheath, or do you do that?
So-
To be honest, we don't. We have access, but we don't put a wire up.
Yeah.
Okay.
So we don't
Okay.
put a wire,
We can do
we
that
just make sure that before the sheath is completely
Okay, we'll
out,
take it out.
we inject from the other side
Wait, get me
with
the
an IMA
ProGlide
catheter
knot tie up, please.
and just look at the vessel.
So that you have access, immediate
You have
access.
immediate access if needed. But then immediate access is also possible
Exactly.
because you also have the sheath and the dilator, which if you see any leaks, you just push it back. So the best way is have the dilator. That's why it's got a dilator. That's why it's got a stiffer wire. Because if there's a perforation,
remove it out?
the first step is just push everything back. That seals
Yeah, I'm gonna hold this.
partially
Okay.
Yeah. Okay.
the perforated artery,
Yeah.
and then you have time to act.
Leave it.
So now Sengo is closing the femoral axis. He's already removed the
Bernard,
Can we
Bernard, can
home in
we-
on the closure, please?
Yeah.
Keep it
Please.
separately.
And we can take the echo off the screen and the fluoro just to see Singo's hands.
Yeah, perfect. Can we have a better view to see the skin of the patient?
So we have just.
So Thierry, what's
take
your
the camera
practice? And can you tell everybody your practice
This is a-
about closure of the
So-
per close on the wire?
Yeah. So we use two per close, provisional when the femoral is small. We close always on the wire, the first and the second one. And then before removing the wire,
So there is no bleeding at all after we can remove this.
it depends, but in some cases we do an angio just to be sure that everything is okay when we have a dub.
So
In other cases, and it is the majority, we just remove the wire and make the final control.
The final?
Final control
injection.
of the femoral. But we
Control
use
injection.
so we
what-
use the transradial approach
Yeah.
Yeah.
for that.
So if once you have put both proglides,
Yeah.
still there is a big ooze happening. So what is your approach in that
After
kind
the
of
two
situation?
proglides,
After two proglides.
after the two
we
proglides,
wanted to check
we,
and then decide to do the second one.
we use usually the angioceal. Angioceal.
Yeah. So
But
he-
you know, the problem is that if you use angioceal, so what we have devised, I mean, what we do is, after two proglides, if there is a big
They
ooze,
died, Mala.
then what we do is we put a 6 French sheath. If the 6 French sheath closes the
So
leak,
what we have
then
done
use
is
the angioceal.
we have just done.
Otherwise, third proglide.
I think one
So
of the
what
one
we
of
have done is just we have done only one proglide, not the other one is still not. We wanted to check and see, and maybe he will just leave with one proglide.
So you don't have any bleeding anymore.
Yeah, there is not much bleeding. There's minimal ooze there.
Kentaro, there is a very, very minor ooze. We're just going to check
Okay.
it with a pigtail angiogram.
Yeah, we need to.
That's great.
You want to connect and do
Good
a
news.
pigtail angiogram? Yeah.
But you only tighten one proglide.
Dude, I'm bleeding in the sheath.
Okay.
So this is basically to prevent the cinching of the vessel.
Yeah.
Is that
Show
right,
it
Dr.
this side,
Bernard?
Andrew.
Okay, ready?
Can you show this side? Can you move? You have place to move? Okay,
There,
okay, right,
okay.
right, that's fine.
Ready?
We
We can
do
do
a
a
selective
selective
injection or? Okay.
Yeah.
It looks very nice, hey?
Yeah.
Yep. Beautiful.
looks nice.
Beautiful closure.
There is no
So we're
pinching
going
of
to
the
tie
vessel.
the second one, Sengo, or just leave it?
I feel should leave it. What do you feel?
I agree. We don't want to cinch the vessel now with the
Yeah.
second one.
So this is a provisional
So
to
blade,
proglide
please.
technique. I think
That's the
it's-
provisional steps that you were talking
Yeah, yeah.
about.
I think it's very good.
So would you like to do the aortogram to see the valve or not?
Yes, we will do it.
Yeah.
We
Okay.
can do it before we
Aortogram.
take the pigtail out.
Okay.
So when you have this
So we
kind
should maybe
of
have a
Bleed.
discussion, Kentaro and Thierry. We have relatively narrow left bundle branch block. What's your view about leaving the temporary wire in?
so what is the QRS width?
QRS is probably 140.
140. For me, it's okay. So no pacemaker.
What reverse that one?
So what's your
Ashok,
150,
your
yes.
experience with the MyVal?
yeah the likelihood of this progression is very small, and I'm not concerned about it. So yeah, I mean I think I would send the patient to the CCU with the wire, but I'm not necessarily going to keep it for overnight. I would actually pull it out
Sure.
the moment I'm more comfortable with that. That's all.
So if
Because
you-
it's a new onset, I just observe it for a few hours,
Yeah.
but not overnight at all.
Yeah. So what we do in my lab is that the patient is going to the awaking room for 1 hour, and we redo the EKG 1 hour later. And usually the QRS width is smaller, and sometimes it's the opposite. So sometimes we put a pacemaker before the patient is leaving the room. But in this case, 140, I think, yeah, it's okay. And the risk of pacemaker is relatively low. With
Yeah, this
My
would
valve.
recover by next day.
seems to be 4
So-
or 5%.
But I think you got to be safe. Remember, you're all in your early cases. You can't just go, you actually have to be avoiding every complication. Bradycardia and asystole are bigger killers than VT and VFs because it takes time. It takes no time to cardiovert a patient, but it takes time to put in a pacing wire.
Since we don't have to move the patient to the
Correct.
ward immediately, the patient has to still stay in CCU.
And you're going to keep him in CCU for 24 hours. And the fact that he's got a temporary pacing is nothing wrong with that. So I don't think that you go to, for something like this, while you can understand that this is temporary, and we're going to observe it for a few hours, the fact that you observe him till the next day is nothing wrong with that. You're just being safe rather than sorry.
So what is?
And by the way,
since,
none of you should start believing that you got to do minimalist TAVR right from the beginning. You got to do a safe TAVR from the beginning. You're not in a rush to send the patient home and try and boast that I sent him in 2 days' time and I didn't put anything in. You'd rather have a patient for 5 days who's actually spent so much of money, provided he goes home fine and alive. You will get to that stage when you'll send your selective patients home in 2 days' time. But you don't have to start believing that that's the way to do TAVR in your first 10 patients.
No, but in this patient, I think leaving the lead for 24 hours is reasonable.
Yeah, for a few hours is reasonable.
In our setting, it's quite reasonable.
Okay,
So be safe.
What generally I do in this setting is to remove the pacemaker.
So my own practice also would be to remove the temporary wire, but I think as Ashok is saying, you need to be cautious and you need to put safety first. That's a very, very important point. Thierry, I think you have a question.
Not me, but...
Okay. So in which case, I think we can proceed to the aortogram.
Caudal.
Yes, please.
Caudal.
We need to remember that one of the issues that we raised in advance was the relatively low left main stem origin.
Okay, picture.
So it'll be interesting to see the flow down the left main.
Okay, ready?
Can you make in a big screen?
So let's have now the aorta.
Can you show the
aortogram
big
on the
screen?
Big screen.
Show the big screen.
Yeah, very nice.
Show it in big screen.
No AR.
So as you say, there is no aortic regurg, very nice flow in the left main, and a very nice deployment height.
Yeah, and the position is perfect because
So maybe I should...
you have access to the left main without any problem if needed. Okay,
Exactly.
so we have a question.
So maybe I should summarize at this stage.
Yes.
I can see the clock. We have maybe 5 more minutes to go. So we'll summarize here from the catheter lab, and then you can close the session in the main arena. So we've seen a very nice demonstration of TAVI in a patient with a bicuspid valve, 75 years of age, with a low left main stem. We had quite a difficult job in crossing the valve. Sengo did that very skillfully. We then undertook preliminary balloon valvuloplasty with an 18 millimeter balloon and deployed a 23 millimeter MyValve device with a long pacing run, a very slow implantation, and doing that we achieved a very nice stable position and a very nice lasting result here. We've got minor partial left bundle branch block with a QRS of 140, and we'll have a discussion about whether or not to use a temporary wire for 24 hours. And all of this procedure has been done through the right transfemoral artery, ultrasound guided, with perfect hemostasis with a single ProGlide. So Sengo, it's been a great pleasure being here. You operated very coolly under pressure. We've got a very nice result for this patient, and you've been supported by an excellent team here around you. It's been a pleasure to be with you.
Thank you so much for being here, and it was nice working with you today.
And also, let's sum it up by saying you had one of the finest co-operators in the world with you today.
Yes, this fellow here.
Yeah.
So thank you and congratulations for this great case.
Thank you
very
much.
much.
Thank you.
Thanks. Thank you.